All right, we're going to get started. Lunch is an incentive for getting started and moving on.
Judging.
All right, is that better? Okay. I'm Madelon Baranoski. I will introduce the panel as they present. We're presenting now on encounters with the justice community and opportunities for intervention. And I'll point out a lot of overlap will occur when you see some of our slides and some of our points, but they're incorporated here because they're making a different point. The link between prisons and mental health goes back, at least in the American and European history, way back to the 1700s and before. Dorothea Dix, a reformer in the United States, but the Quakers in Europe, moved to get people with mental illness out of prisons. They were moved at a time when there was no effective treatment. And so the purpose of that movement was to make them invisible to the public, but still treated humanely. So the ostracism of the mentally ill before effective treatment was an acceptable goal from a public health point of view, from a professional point of view, and even from a religious point of view. Without effective treatment, containment was all we could do. And so communities built up here and in Europe. They were called state hospitals. The first state hospital in the United States was in 1790, and most of them were on the East Coast. They were self-contained communities. People worked there. The professionals lived there. People who were patients worked in the communities. And this is what they look like now. I commend to you the book by Christopher Payne. It's a pictorial discovery of what happened to all the asylums over time. What happened to the asylums has a direct impact on where our mentally ill people are being treated now. So medicine and the law partnered in the deinstitutionalization. The first factor were the discoveries of neuroleptics. But as you can see, it didn't have a big impact. So people with severe mental illness, mostly psychotic illness, and what we consider bipolar illness now, could live in the community, could be left out of the hospital because of medications that primarily sedated them. Medicaid did introduce a payment schedule for services that were not paid for before. But what really made the difference was the law. The Supreme Court in 1966, in Backstrom v. Herald, told the state of New York that they could no longer do what they were doing. And what they were doing was taking prisoners who had served their entire sentence who were mentally ill and just moving them over to a mental hospital. And the Supreme Court said, no, you can't do that. You can't do that until you show they're dangerous. And within days, those state hospitals had to discharge all of the persons who were there under that transfer. The newspapers were filled with predictions that the streets would be filled with violence, and none of that occurred. There was no violence secondary to that. In another Supreme Court ruling, O'Connor v. Donaldson in 1975, the Supreme Court said you can't keep people in a mental institution who have support in the community. And if you notice on this graph, in the 60s, that's when the deinstitutionalization began. Up until that time, up until the 1960s, there were no voluntary patients in psychiatric hospitals. The term wasn't used. People could be committed, and the shift that occurred was this. The person had to prove they were sane to get out, and what the Supreme Court decisions did was shift that the state has to prove dangerousness. But the shift to the community did not guarantee care, housing, work, or supports. And so people left the institutions a community of institutions, were not ideal care, but were moved in the community with no backup. And families were ill prepared to care for them, and there weren't institutional services. And the act of the Community Mental Health Act did not provide enough money to provide all the services that were needed. And so the result was a trans-institutional shift. Now it is wrong to assume that people came out of mental hospitals and went into jails. That's not true. What instituted the high rate of incarceration in this country are a number of other laws. But there was a shift. People who would have been in a mental hospital, a number of them ended up in prison. And you can see on this graph that Dr. Fox will also show that at our time right now, we have moved from 1 in every 300 Americans being in a psychiatric hospital to 1 in every 200 Americans being in the criminal justice system. And why we know it isn't just the shift of mental illness is if you look at the United States compared to the rest of the world, we jail more people. We're the leaders in incarceration. Mandatory drug sentences, the discrepancy between for sentencing for cocaine versus crack is another factor that has increased the population in our prisons. And a large percentage of those people have mental illness. These pictures drive home something. This was an asylum, and this is a jail. This was an asylum, and this is a jail. And people argue that our greatest loss of human resource is because of our prison systems. Where are the people with mental illness? If we look at 1963, before the deinstitutional impact, you can see there was a large number in mental hospitals. Still, many lived in the communities within families or supportive communities. Now, in 2003 and beyond, the shift in homelessness for people who are mentally ill grew dramatically, and the shift to prisons. Many fewer are in psychiatric hospitals. So the interface with, if we look globally, an estimated 1 in 4 people have a mental illness globally. And I think you've heard most of this, but I want to point out that across the world, between 15 to 90% of people in prison have a mental illness. In Haiti, for example, the estimate is around 85%. And that includes substance abuse, but not just substance abuse in remission. The lower prevalence in low-income countries is often related to underdiagnosis and assessment. So in some countries, when you look at the prevalence of mental illness in prison, if they're not assessed, it won't be identified, and it drives the prevalence alone. In the United States and Europe, the estimates range from 25 to 75%. The underserved population of persons with mental illness end up contributing to the shift to the jails and prisons, but also to the criminal justice system. The majority of people with mental illness who are arrested, however, are not arrested on violent crimes. Most of them are arrested for nuisance crimes. And in a study that we did in 2004 in New Haven, we looked at the people arrested for breach of peace, who then could not resolve their case before the judge immediately after being arrested. I could ask you who you think the people most likely to be arrested for breach of peace were, and we'd say, well, probably the mentally ill, but they were actually college students. We have a lot of colleges in New Haven, and when you have a big beer bash, a lot of arrests happen, but all of those people could talk their way out of going any further before the criminal justice system. People with mental illness, however, got jailed with a breach of peace, a very low charge. Poverty, low education, limited housing and resources, and stigma and discrimination that you've heard of all contribute to the increase in numbers of people with mental illness in prison. It's not that they're more violent. It's that their life is destabilized and they're more likely to come to the attention of the criminal justice system without support. In addition, the stigma, the view of the public of their being dangerous or a nuisance, increases the demand for the justice system to take control where it looks as though the mental health system has failed. And you've seen this slide that was very well presented before, so I'm not going to spend time on it. I will show you, though, if you look at the mental health professionals per 100,000 by income of country, you see even more disparity. So and in the United States, the distribution of psychiatrists correlates with the income of the states. So the Gold Coast of Connecticut has a very high number of psychiatrists, and I'll bet in Chicago, the richer section of Chicago will also have a higher number. It's the distribution, not by choice of physician necessarily, but by choice of private payer and who can afford services on their own. So the interface across the criminal justice system we're presenting today because jail and prisons are the last steps. But the interface begins with the policing, with the arrest. It moves through the courts and the adjudication. And then if all else fails, if all diversion fails, it ends up with prison. The issues across the criminal justice system are complicated because they're not just the mental health questions, the societal questions of the epidemiology. It involves the law. It involves the civil rights. It involves the application of law within any community. And that's why we're fortunate to have our panel today. And the bios for the panel are in your packet. And with the intent to preserve time, I'm just going to introduce them by name. Our first speaker is Dr. Goldberg, who comes from Johns Hopkins University. It'll go right to, there you go.